Hello, a very good afternoon to all of you once again from Team Nova Southern Fertility and IVF New Delhi. I'm Dr. Vandana Bhatia, Senior Consultant from Nova Southern Fertility and IVF. We welcome you all again for our infertility related issues and online webinar series. We have talked about COVID, we have talked about endometriosis, we have talked about third-party reproduction. On another very important topic related to fertility, which is very challenging and enigmatic, and that is PCOS. Polycystic ovarian syndrome is a health problem which affects 1 in 10 women in childbearing age group. These women have hormonal imbalance. These women may have metabolic problems that may affect their health issues and appearances. The problems of PCOS may start early in life, during the adolescent period, or in childhood. So the gynecologists, the endocrinologists, the pediatricians, they are all involved in this, and they look at this problem with different perspectives. But if we talk about infertility, nearly 1/3 of all infertility diagnoses in women, PCOS is the most common ovulatory disorder in women. That means these women have problems related to their ovulation. But there are many controversies, many challenges when dealing with a PCO patient, and there are so many questions which are still unanswered in this context. There are many gray areas in PCOS research and its clinical application. And the biggest challenge is we still do not know what is the exact cause for this disorder and when does it begin. That is another challenge. Then with this come the challenges in the lifestyle, the challenges to define the diet, define the drug interventions which these women require. While myths do persist that PCOS women cannot get pregnant, but the reality is that it is a highly treatable condition as far as fertility is concerned, and nearly every woman with PCOS should be able to get pregnant if she's getting the right treatment at the right time. But all what we require is patience and dedications, because we require an adequate amount of time for lifestyle modifications and other things like weight loss. And in fact, most of the women may experience the increase in fertility even through little bit of lifestyle modifications, little bit of dietary changes. Others will find success with basic infertility treatments and addition of certain drugs, while a small subset would be left who would require things like IVF. But infertility management, though, can be offered to all these patients, but the success rates are not the same. Developing algorithms for these patients can be challenging because these patients behave differently. PCOS in one woman, a PCOS woman will not behave in the same manner as another PCOS woman. So this is a great challenge. And with this in mind, even in India, under the dynamic leadership of Dr. Sonia Malik, certain guidelines and good clinical practice recommendations were developed, were formulated, keeping in mind the Indian polycystic ovarian patients, keeping in mind that we have different, genetics, we have different ethnicity. So certain guidelines were recommended, but still we have a long way to go. And the patients do have a lot of questions which we still find it difficult to answer. And today we have with us Dr. Gunjan Sabharwal, who is a senior consultant at Nova Southern Fertility IVF at Gurgaon. And she would be here to answer most of our queries, most of our basic questions about PCOS, related issues related in IVF, related in lifestyle modification, as to what is this disease all about. So I welcome you, Dr. Gunjan, and we shall start from here.
Thank you, Dr. Vandana. Thank you for the nice introduction.
And Dr. Gunjan, to start with, the first and the foremost thing that I want the viewers to know is what is a polycystic ovary. When we talk about polycystic ovary, everybody connects to its syndrome. So there are two different terminologies: polycystic ovaries and polycystic ovarian syndrome. So could you please highlight what is the difference between these terminologies, and what would be the importance in the clinical application?
Uh, as we know that polycystic ovarian morphology signifies the ultrasound description of the ovary. It the ultrasound detects whether the ovary is the size of the ovary and the number of follicles in it. So criteria have been devised to define polycystic ovarian morphology, which is called PCOM. So herein we have more than 20 follicles of the diameter of 2 to 9 millimeters, and the ovarian volume can be increased. It may be more than 10 millimeters cube. Now, a PCOS is a polycystic ovarian syndrome. As per the dictionary definition of a syndrome means a collection of symptoms which are consistently present together. So polycystic ovarian syndrome is actually it's a symptom complex of number of symptoms grouped together. It is one of the commonest hormonal imbalance endocrinopathies which girls have in the reproductive age group, and we find it throughout the spectrum from the age of 15 years to almost 49 years and beyond. And it has lots of short-term and long-term consequences. So basically in PCOS, there is a problem or imbalance involving three groups of hormones. One is the male hormones, second is the insulin, and third is the progesterone. So basically PCOM is probably one part. It can be seen in few patients with PCOS. So seeing this, we have a criteria called the Rotterdam's criteria, which guides the clinicians how we can place or group a patient under the category of being or of having PCOS. So according to the Rotterdam's criteria, there are three things which we have to see. One is the excess male hormones or hyperandrogenemia, the ovulatory dysfunction, and third is menstrual irregularities leading to anovulation or oligo. Fewer times she is ovulating. So depending on this criteria, we can group the patient as having. Not all the patients who have PCOM can be having PCOS. So in fact, patients with PCOM, the ultrasonic picture of a polycystic ovarian morphology, 16 to 25% of these girls can be regularly and normally menstruating, and it can be a normal finding in a girl who is transitioning from puberty to adulthood. So hence we cannot say that PCOM is always having a pathology.
So that gives a message to the girls and to the mothers who are watching just having an ultrasound picture saying that she's having polycystic ovaries does not mean that they should get worried, they should get alarmed, they should be, still it is the syndrome. These girls may not have any kind of syndrome, and in fact, if I correctly say, then it is too early at the age of 14 or 15 to label a girl as a polycystic ovarian syndrome.
Very true. And I would also at this point like to show a slide to highlight what a polycystic ovary is, a polycystic ovarian morphology.
Okay, please go ahead.
Thank you. Yes, so on the right side, we can see on the left side is a healthy ovary in this picture, whereas the left side has a slightly enlarged ovary with a few follicles, which are more in number, like we can see few of them. So if we see the ultrasonic picture of this, we would, is this clear? Is it
Yes,
visible?
I can see that. I can see that.
Okay. Now, I would also like to show an ultrasound picture of what a polycystic ovary actually looks on an ultrasound. Yes. So this is the picture of an ovary, which is studded with small follicles. Their diameter apparently looks less than 10 millimeters. And there are multiple, say around more than 20 for sure. And it is an enlarged ovary. So this is actually how a polycystic ovary looks like on ultrasound. And majority of our young girls and their mothers, they literally have a panic attack when the doctor, after doing an ultrasound for maybe some menstrual complaint, reports the possibility of her having polycystic ovarian disease.
Right.
So hence the message, of course, should be clear that, sorry. So the message should be clear that polycystic ovarian ovary does not imply polycystic ovarian syndrome. For a syndrome, we have to have few symptoms for her to be labeled under that category.
Right. So coming to the next question, basically prediction for the syndrome or specific cause which leads to a PCOS?
I'm sorry, I didn't get the question.
Is there any specific cause? Like the patients would come in the OPD and they would polycystic ovaries.
So as you had rightly mentioned in the introduction, that there is no known cause as yet which has been discovered. But there are few conditions which are more associated with people having polycystic ovaries. So like hereditary, there probably is a role of genetics, because we find that women or girls may have a history of her mother or sister or any of her first degree female relative having polycystic ovaries. So it could probably be through hereditary reasons. There, in some cases, insulin resistance has a role to play. That is why commonly we find that the girls with polycystic ovary, if we take a detailed history, often there is a family history of diabetes in their parents or in their first degree relatives on the paternal or maternal side. Another cause which has been attributed is a low grade chronic inflammation. This is a cause especially related to the gut. They have seen that this sedentary and environment and a lot of junk food, all these they point towards a low grade inflammatory state, which also can be is associated with polycystic ovarian syndrome. So basically we cannot pinpoint what is the cause, but in nutshell, there are some trigger factors also. So a sedentary obesogenic environment wherein the girls are having lots of junk food, they're not exercising a lot. And there are environmental toxins, smoking for instance one, and of course the environmental pollutants. All these put together along with the basic factors which we have pointed out can probably have a role in the girls having more, they are coming up more as polycystic ovarian syndrome.
So there is not one specific cause which can be labeled.
No, it cannot be pointed that this is the particular cause why a person has PCOS or doesn't have PCOS.
And if we talk about the symptoms of PCOS, if we talk about the symptoms, So
Yes.
what are the patients like who walk in your OPD? कई बार ये होता है कि yes, from the look of the patient, we can know she's a polycystic. She's having polycystic ovaries, or she's a patient with polycystic ovarian syndrome. So what are the symptoms that these patients will come up with, which will help us to know that yes, she can be, she can fit into this category?
Yes, of course, it's a very, very common problem which all of us encounter in our OPGs. So I would like to again share a slide for the ease of the viewers, because it makes it easy for the symptoms to be evident. Uh, just a minute, please. Okay. So herein, basically, it's a representation to show that what kind of symptoms we commonly have, the problems which girls come to us with. Starting with the commonest, there is this picture which shows, but the commonest symptoms which most of us gynecologists face is menstrual complaints. So menstrual complaints, as in the patient may have irregular menses, they often skip their periods. The flow may be erratic, sometimes it's scanty, sometimes it's very heavy. So the concern with the mothers and the young girls is that they are having very delayed periods, and they are infrequent, in the sense sometimes it's 1 month, sometimes it's 2 months. So there is no regularity in that delay also. Then seeing now again coming to the problem where sometimes the girls come to us with having features suggestive of excessive male hormones. So there could be hirsutism, that means male pattern hair distribution in the body, like in your upper lip, the chin, chest, the upper abdomen, back, and your thighs and arms. So this is a very common problem. It's more disturbing when it is prevalent more on the face. Sometimes the girls have a sudden increase, a history of excessive weight gain. So the mothers are very worried that since the weight has increased, she has started to show these symptoms of excessive hair growth and missing her periods. This is for young girls. Then they might also come to us with the psychological problems because of self-image, like sometimes they feel very depressed, there is a lot of anxiety, there are sleep disturbances. Then young couples come to us with infertility issues, that they are trying to conceive and conception is not happening. And now seeing this, there might be sometimes a history of excessive hair fall, for which we often divert the patients to a dermatologist. But the underlying cause could be a PCOS. There might be acne, which is resistant to treatment. So basically over the physical image of the girl, she feels worried about that. And sometimes we have associated symptoms. A young girl might present with high blood sugars, and on further examination, we find that she is an overt diabetic. Now, there might be some issues with the lipid profile. There might be a high cholesterol or high triglyceride, which is seen in these girls. So basically, it's an overall symptom which is affecting the overall body from top to the bottom, and gives a lot of concern once the periods are not regular or she is having fertility issues. So.
And thank you so much for this slide, Gunjan. And a frequent question which a patient who walks in our OPDs asks us, can I still get pregnant if I have a PCOS?
Yes, that is a very valid question. Yes, she can get pregnant if she is having PCOS. But after saying that, I would also like to add that pregnancy is, we have to achieve pregnancy after first investigating in totality the couple. It is not only the female factor, not only the person having PCOS that we say that she can conceive. Yes, the couple can conceive if there is no associated male factor and her hormones are within the range where we can correct or can be modified. So sometimes, as again I said initially, I said that PCOS is throughout. It's a spectrum. It's over a spectrum. The signs and symptoms. So depending on what kind of presentation a patient is coming to us, sometimes a simple maneuver like lifestyle modification can help us achieve a pregnancy. Sometimes we might have to give medical assistance, as in we might have to give her some medication, we might have to do a procedure like IUI or go in for IVF. So basically in PCOS, the problem is it's an ovulatory malfunctioning. So the function of the ovaries is hampered. So either there could be no ovulation, or they could be scanty, infrequent, or it could be an erratic ovulation. So what kind of medication is required for this patient has to be assessed after conducting the tests and after analyzing the couple. Because if we have a male factor associated, or there are other factors like a tubal factor, or a low ovarian reserve, or a woman who is more than 35 years of age, then our management, and it can become a challenge to help them conceive.
So you've answered the next question that I was going to ask you is that how the PCOS, it leads to infertility. So basically what I understand from this thing is that it is the ovulation which is hampered in a PCOS patient. These patients are not ovulating. So if they are not ovulating, then their chances of conception are obviously going to be less. So basically we have to help them out there, of course, excluding other factors as well of infertility. So this is where infertility is concerned. As far as other things, other health issues are concerned, are there any other health problems which could be associated with the PCOS, or which puts these women later on at risk for some other kind of diseases?
Yes, PCOS has a lot of long and short-term consequences associated. Primarily for this reason, it is a very important topic of concern for most of clinicians. And we have to educate and make our patients aware of those consequences. So starting from a younger age, if we see, there could be, because of her faulty physical appearance, the patient could be having psychological issues. There could be depression and anxiety in a patient. A young girl, because she is obese, can also have sleep apnea, which is again a problem which can cause general debility and fatigue. Now, coming to the insulin resistance, which is our main concern in patients with PCOS, these patients tend to become overt diabetics much earlier in life. They may have deranged sugars in their reproductive years, which may cause a delay in their conception, and later on in life, they may become overt diabetics very soon, or in any stressful condition like maybe pregnancy. Now, because majority of these patients are obese, they can also have an abnormal lipid profile, making them prone towards having cardiovascular accidents. So they can have atherosclerosis, high blood pressures, and sometimes, unfortunately, can also land up in stroke at a much younger age than actually we find in the population. Now, because there's another problem, which, as I earlier mentioned, it's a progesterone deficient state. So indirectly, there is an estrogen excess, or there is an unopposed estrogen, which is playing a role on the endometrium. So in patients with PCOS, many a times we find that there is a tendency for the endometrium to overgrow and become hyperplastic and cause dysfunctional uterine bleeding, or at a later date may present as endometrial carcinoma. Now, another problem which we often see in polycystic ovarian patients is that they also have a tendency to form ovarian cysts. So that could that may lead to increased morbidity or an operative interference as well. So these are some of the broader things which we have to deal with in patients with PCOS.
So these are the long-term consequences which may happen if not taken care of at the right time. And this sends a very strong message across to all our young patients that they should not worry about this. It's not that they are going to have this definitely for sure, but it is just that they are at a slightly higher risk than their normal counterparts. And by doing a lifestyle modification, taking care of their own physical and mental health, they may not face any problem at all. The bottom line is that they should be really taking care of their lifestyle and their weight. So moving forward, as you have said that you probably answered that question, the diagnosis of PCOS being based on the history of the patient, being based on the ultrasound and certain investigations. And of course, what is the role of the ultrasound in this? Because many a times, we see that the young adolescent girls are diagnosed to have a PCO. So is that the right time that a 14-year-old or a 13-year-old can be diagnosed on the basis of an ultrasound? Or you would like to add something?
No. So ultrasound is one modality which helps us come to the diagnosis of polycystic ovarian syndrome. It is not the sole modality. So as you rightly said, that we have to go into a detailed history, a personal, a family history, a history of her daily activities and her addictions, plus her menstrual pattern. The second is, of course, a detailed examination. We have to see the patient in person. We have to see her BMI, her signs and symptoms suggestive of excessive male hormones, her blood pressures. And of course, ultrasound is one modality which would add on to our checklist for putting the patient under PCOS group category. The other important, yes, as asked by you, that these days the guidelines say that menarche, after menarche, till up to 8 years post menarche, there is still transitioning happening in the body of a young girl. So we cannot, a polycystic ovarian morphology ultrasound will not categorize the patient as having PCOS if it is done in that time span. So to add on to that, we have to add the blood tests. So for the blood tests, majority of the labs have a PCO panel because it is such a common problem. So they do have a PCO panel wherein they do, it is recommended that the fertility hormones are done on the second or third day of the period for the patient. Tests should be done to see for any excessive male hormones. And of course, we have to see her baseline sugar status. So the hormones which we recommend are the FSH, LH, AMH, and estrogen values. Along with PCOS, sometimes mild hypothyroidism or prolactin disturbances are also seen. So these are the two other hormones which we test routinely, the thyroid and the prolactin. And of course, we do the sugar testing and serum testosterone if there are symptoms or signs which suggest excessive male hormones.
So the tests have to be individualized based on the age of the patient, based on the problem that the patient is coming to us, and based on the physical examination of the patient. Right. So as you said that there are 3 to 4 criteria which define whether the patient fits into this polycystic ovarian syndrome or polycystic ovarian disease. So in these criteria, are there, when we see in broader aspect the whole PCO, the whole frame of the PCO patients, are there any different kind of PCOs, or are there any subsets that you would see in your practice that, well, this is also a PCO, this is also a PCO, but this PCO is different from this PCO?
Yes.
So how would you define that?
Yes, as I mentioned earlier, we have for our clinical aid, we have a criteria called the Rotterdam's criteria, which defines the three factors for which we have to look for in a patient of PCO. So they are hyperandrogenism or excessive male hormones. So this can be done by either the clinical signs of symptoms or can be done by the blood tests which we do. Then we have ovulatory dysfunction, which is seen whether the patient is ovulating or she is infrequently ovulating. So that is the ovulatory dysfunction. And the third is the with the help of ultrasound, the polycystic ovarian morphology. So the permutation and combinations of these under these three categories would help us divide and place the subject into 4 types of subsets. So there is a subset that is the type A, B, C, and D. So A is the category wherein we find all the the features in the patient. Now, in category B, we find signs of hyperandrogenism and ovulatory dysfunction. So these patients may not have an ultrasound picture which shows a polycystic ovary, but still she may be a polycystic ovary. She will have others hormones, or her tests will reveal polycystic ovaries. The third category, or the C category, is where there is evidence of hyperandrogenism or excessive male hormones, and they do have a ultrasound picture carrying a polycystic ovary, but they are ovulating normally, they are having normal menstrual cycles. Now, and the fourth category is when they are having ovulatory dysfunction, and they have a polycystic ovarian picture on an ultrasound, but they do not have any evidence of acne or hirsutism or suggestive of any male excess of hormones. So broadly, if I would say, we could probably group them into the metabolic group and the other one with a reproductive group. And then there is the majority, most of them, they fall into a group where they are taking features from both of them. So in the metabolic group, there is more, what we find is more of insulin resistance. But in the reproductive group, there is more of hormone imbalance. So then we have a subset, then the other, we may not have the people exactly in the metabolic group or exactly in the reproductive. So then they have features from both of these groups.
Correct. So according to probably the subset or the phenotypes, we may call them, so they would probably require different kind of treatments, yes, and the individualization will have to be done. So all the PCOS will not require the same kind of management.
Exactly.
When we talk about fertility, what are the medications, or what are the first step that you would advise your patient? Suppose a patient comes to you and we diagnose that she's an anovulatory patient and she's not ovulating, and that is the basic problem. So what would be your first advice to her to improve on that issue?
So as we know that the underlying problem is, or the trigger factor is an abnormal lifestyle. So lifestyle modification has a lot of role, lot of importance, and it is probably the first line of management for any patient with PCOS, whether she has come to us for fertility issues or menstrual problems or otherwise. So in lifestyle modification, as we have seen earlier, that it is the modern day obesogenic environment, a sedentary environment, which is causing, it is triggering these, a cascade of events wherein the girl presents as a PCOS. So we have to revert these. We have to make her more active. We have to make her aware of the right kind of diet, the right exercise, and a right disciplined lifestyle which she has to lead. So again, I would like to just share a slide with you which can help us understand how important this is. So as we can see that here, in lifestyle modification, we have to exercise regularly. Now, according to the Indian National Good Practice guidelines, which have been made by our mentor, Dr. Sonia Malik and her team, so there is a lot of importance on the right kind of exercise. So, according to those guidelines, a girl should be exercising at least 60 minutes a day on a daily basis. Um, they have also laid a lot of importance on adding yoga in the dietary in the exercise regime. So yoga is a very holistic, I would like to just say a little about this. It is a very holistic kind of an exercise, and the best part is it can be done at any age group. It can be modified according to what how the body takes it. It not only takes care of the exercise as a protocol under treatment of PCOS, it helps in countering obesity as well as stress. And these two again are very, very important to take to consider as for treatment under PCOS management. So yoga has can allay anxiety, it can improve our general psyche, and it helps in weight reduction. It helps to improve the blood flow to our genital organs, especially to the ovaries. And it can go a long way, starting from 15 years to 50 years and maybe beyond. So hence it is recommended that patients who have PCOS should include yoga if possible in their daily exercise routine. Now, eat healthy. What does this mean? This means that the girls should be aware that junk food is like poison for them. Then they should be having a low carbohydrate, low fat, and a high protein diet. So, according to the recommendations by Dr. Malik, it is said that they are advised to lose 5% of their existing weight, and this is going to help us a lot. One, with the symptoms, she might start menstruating regularly, she might start ovulating regularly, she might start responding to medications also with just a 5% weight loss, and she will delay the onset of the metabolic problems. So hence, eating healthy and exercising regularly are very, very important. Then reduce stress is, yes, of course, yoga is a big aid in that, and other exercises will also help. And of course, we know that drinking plenty of water anyways is a good thing. So a healthy lifestyle is going to help her lose weight, which is again going to help us correct her hormonal imbalance.
Correct. So I think that is a very, very important message for all the girls and all the young females out there with this problem, and especially in these COVID times where everybody has been shut at homes. They have I would say they have a good excuse not to exercise, not to go for a brisk walk. But definitely the clear cut messages, even if you are at home, please do your fitness regime, please follow these things diligently, because then I believe, Gunjan, it becomes a very vicious cycle. Once the patient starts eating in and there is an increase in the weight, because there are certain subset of PCOS where even after trying very hard, they are able to lose very minuscule of their weight, and that gives them a sense of depression, and they start eating more. So it becomes a vicious cycle. So the message to them is that they should not be losing heart, they should not be giving up easily, and they should be exercising, continuing with their exercise. At least if they are not losing, they should not be gaining weight.
Yes.
Right. So if we are concentrating on the fertility point of view, what are the medicines which we, one is the lifestyle, the first step is the lifestyle modification, as you have said, and then coming to the second step, if the patient is anovulatory, what are the basic medications that we can do? Are there any medication, first of all, to improve the ovulation, to make them ovulate?
Yes, so now let us see what are the problems we have to tackle while we are kind of treating a patient with PCOS. So one is the ovulatory disorder, primarily when she comes to us for fertility issues. So for, as I have told earlier, that this is a ovulatory malfunctioning disorder. So hence we have to give medicines which will help us improve the ovulation or initiate the ovulation. So for henceforth, we have to give ovulation induction agents, drugs. So these can be given in the form of oral or injectable. So these are medicines which will help us, one, if she's not ovulating, to initiate ovulation. Two, if she's not ovulating at the right time, to properly time the ovulation. Three, if addition of gonadotropins or injectable ovulogens will also help us improve the quality of the eggs in these cases. Now, the second part which we have to take care of is the insulin resistance. Insulin resistance, to quite some extent, is an inherent tendency, but we have to counter it by giving her insulin sensitizers. Now, this again is a very important group of medicines, because once we prescribe an insulin sensitizer to a young patient, the foremost concern to the parents and to the family, which is probably created by the chemists, is that, oh, she has become a diabetic. She's a diabetic at that age. So this is important for us to console or to counsel the patient that and her family that insulin resistance is also an underlying feature in patients with polycystic ovaries. So henceforth, it is not, she hasn't become a diabetic, but we are countering the insulin resistance. So henceforth, a medicine by the name of metformin, which we have commonly heard about, is given to these patients. Inositol is also one medicine which has a role in helping with insulin resistance. Now, coming to the menstrual abnormalities. Now, if a young girl who is not seeking fertility treatment has come to us with menstrual abnormalities, so then in those cases, we have to prescribe oral contraceptive pills, which may be either combined estrogen progesterone pills, or they may be progesterone only pills, depending on her case. The third is excess male hormones. Now, if the patient has excessive male hormones, then definitely we have to give her some anti-androgens. So in those cases, we might have to add on medicines like spironolactone, or sometimes ointments or to apply, which are anti-androgenic and which decrease the rate of growth of male kind of hair in the body. Then other than that, there are some supportive medicines which are given to these patients. Vitamin D3 has a role in treating PCOS. Magnesium and zinc are two elements which are required for them. And there is, because we are talking about gut inflammation as one of the causative agents, henceforth there is a role of adding prebiotics to their regime as well. So these are some of the medications which we would use for a PCOS, but definitely not all for all the patients. We have to select, we have to decide on what the problem is, and then accordingly prescribe her the medicines.
So definitely, as you rightly said, that all these medications, all the ovulation induction agents, whether they are the oral drugs that we give them or they are the injectables, the patient has to be individualized. Not all patients will require insulin sensitizers. Not all patients will require injectables. Some patients will do very well with giving simple oral drugs for 5 to 6 days to make them ovulate. Those who are resistant we may shift over to injectables to make an egg. And depending upon what is their body weight, what are their hormonal levels like, or the other things, blood tests like, only then they would require addition of insulin sensitizers like metformin or other adjuvants. These are basically given after individualizing the problem and individualizing the patient. So if in a PCO, what are the treatment options for infertility? One is giving this basic treatment for oral ovulation induction. What is the place if the patient doesn't conceive after giving them oral drugs? Then what is the place, what is the next step forward that we may like to proceed on with? What is the place of an IUI in these cases?
Okay, so yes, PCOS, as it is a challenge for the patient, it is also a challenge for us clinicians. So it can be as simple as achieving a pregnancy with a lifestyle modification, or going right up till IVF and beyond. So as once we have a couple who has been fully investigated, and we take them up for fertility treatment, we have to finally see whether there are any associated factors. So once there is a whole sequence of treatment modalities which we can offer to them, starting from a natural cycle monitoring, when we advise them timed intercourse. Secondly, their ovulation induction, as you have already said. Now, if we go beyond that, then we come to ovulation induction with IUI. Now, what is IUI? IUI is an intrauterine insemination. In this procedure, we are trying to cut short the travel distance for the sperms. Now, sometimes there are factors wherein there can be a cervical factor associated, or the sperms are not that adequately motile, or they are not, I would say they are slightly, fatigued, or yeah, I would say they're slightly, I would not say weak, but they are slightly less motile. So we like to deposit them right in the uterus near the fundus, so that they have a shorter distance to go and meet the egg. So in these cases, what happens is, once we are doing an ovulation induction, in majority of the cases, when we are offering them IUI, so we are trying to assist them by giving them ovulation induction either by medicine, or oral agents, or injectable, or a combined regime. So our aim is to improve because we are improving the quality of the egg, we also want to probably not miss the chance of the patient conceiving naturally. So for that, we help them by we give them the option of an IUI. IUI per se doesn't have a very high percentage over the natural time intercourse, but definitely it makes sure that first, if the contact has not happened at the right time, then we ensure that the sperms are made to reach, or they are given the option of reaching the ovum at the appropriate time. Now, if that doesn't work, then we have to assess the patient again, and we have to then we probably take her up for the IVF, which is in vitro fertilization. So herein we help the patient to cut short the time to achieve pregnancy, because they say that one cycle of IVF in a less than 35-year-old female is equivalent to 6 cycles of ovulation induction with oral ovulogens. So henceforth, if we have lost a lot of time, if the couple is getting distressed because of the treatment, if there are factors like a higher age group female, or a poor ovarian reserve, or a tubal factor, or conditions wherein the IUI has not worked, then we go and offer them an IVF. So that is if sometimes the patient is not ready to take the option of an IVF, and she is not responding to the oral agents, then we have to also give them the option of taking the surgical option, wherein we do a laparoscopic ovarian drilling in selected cases.
So when you're talking of an IVF, suppose as I understand, if the patient has not ovulated, but she has not achieved conception with the basic oral ovulation induction agents and with the natural timed intercourse, we shift on to an IUI, a good ideal IUI, a well-timed IUI. And if still it does not happen, with the tubes being open, with everything else in place, then we shift on to an IVF. Now, considering PCOS, as we know that the hormones are a little haywire in these patients, considering that they have lots of follicles in their ovaries, but still they are not ovulating. So when we take them for an IUI or especially for an IVF, what are the factors which are going to, you are going to take care of as a clinician, especially in these kind of patients, so that they have a very smooth sailing in an IVF? Are these patients a little different from their counterparts who do not have a PCO? Are these patients, do you anticipate that these patients are going to behave differently?
Yes, the basic pathology seems very simple in PCOS, that it is an ovulation malfunction. But as patients,
welcome back again. Sorry, there was some problem with the net connection and the server. We'll continue from here, and we were talking about the PCOS, especially in regards to infertility. And we have Dr. Gunjan with us. So we had talked most of the things, but we were on what problems does the clinician face, or what patients should anticipate, patients of PCOS should anticipate while they are going an IVF cycle. So Gunjan, could you elaborate on this? We'll have to make it a little quick.
Yes, Dr. Vandana. As I was talking earlier, that PCOS is also a challenge for a clinician. So once we have a patient of PCOS, we have to go in a very guarded manner with our IVF protocol. So we have to start with a low dose, and we have to increase it very gradually at not comparable to the counterparts who are non-PCOS. They have to be monitored very closely and very strictly. PCOS, in our clinicians' language, has a phenomenon called all or none phenomenon. So some of them may not respond to any amount of stimulation. Sometimes a dose which is actually high enough, they may not respond at all, or they may respond like the ovaries might just burst and produce lots of eggs. So these things have to be told right at the start of the cycle to the couple, and they have to be made aware of the possibility of cancellation of cycle, of the possibility of a freeze all cycle, so that we do not land up in a situation called the ovarian hyperstimulation syndrome. So also, another factor which we have seen these days is that polycystic ovarian patients sometimes have many eggs, but the quality is not up to the mark. So they have also to be told that in spite of the increased number of eggs which we might obtain, we may not have that many embryos with us. So these are some of the things we have to be careful with a polycystic ovarian patient who's undergoing IVF stimulation.
So what I understand and gather from your message is that, number one, all patients who are going in for an IVF, their protocol has to be very judiciously chosen, depending upon what is the look of their ovaries, depending upon how they have, how they have behaved in their previous stimulation cycles, whether it was an IUI or whether it was with oral drugs, and depending upon other factors, any infertility factors if they have, and of course, depending upon their hormonal profile as well. So the dose of the injections which are used to stimulate the ovaries have to be very judiciously chosen for them, for each one of them, and they have to be constantly counseled that they may respond like a normal patient, they may respond like a hyper responder, too many eggs formed, or they may be a poor responder where we can see eggs but they are unable to respond. So anything can happen, and we have to take each day as it comes accordingly. And as you said very rightly, that we have to be very, very careful for a syndrome known as ovarian hyperstimulation syndrome, where they make too many eggs, where they, the ovaries get enlarged in size, the patient is uncomfortable, and in moderate to severe cases, they may have, fluid in the tummy or fluid in the chest also. So we have to be very, very guarded. And for that, we have to, the final injection that we give has to be monitored. Again, chosen very, very correctly, because we do not want, at Southend, we are an OHSS free clinic, and we do not want any patient to land up in OHSS. Secondly, yes, I agree with you. In clinical practice, we may take out 30 eggs, we may take out 20 eggs if she's a hyper responder, but sometimes the quality is really, really compromised in a PCO. And if the hormones have gone haywire and they have increased, then definitely we freeze all the embryos. We do not do a fresh cycle, and we go in for a frozen embryo transfer cycle where the success rate of achieving a conception would be better. So, is that the gist of the patient who's a PCO undergoing an IVF cycle? So, taking moving on from there, if I talk about, we did not talk about what is the role of surgery. Some people come with ovarian drilling with a laparoscopy, and they ask us whether a laparoscopy would be useful in PCO patient. So what are the indications where laparoscopy should be done for a patient?
So now with the advent of IVF and with the advent of recombinant gonadotropins, surgery has taken a backseat. So laparoscopic ovarian drilling has a role in a few selected cases of polycystic ovaries. Patients who are who have been resistant to ovulation induction, patients who have a persistently high LH or AMH, patients who are who have other associated problems, like we have a PCO but she has an associated polyp or she has a septum. So in those cases we can consider laparoscopic ovarian drilling. And there are in some settings a patient may not be ready to come for intense monitoring, as we have discussed earlier that intense monitoring is required in cases of polycystic ovarian patients when they are undergoing stimulation. So in those cases we definitely prefer that they at least we can help them a little by offering them laparoscopic ovarian drilling.
So the indications have narrowed down as far as PCOS are concerned. But why they have narrowed down? What is the disadvantage of doing an ovarian drilling?
Well, there are a few disadvantages. One, it is an invasive procedure. Secondly, it carries a cost with it. Thirdly, there is a post-operative minor risk of post-operative adhesions. And also an important factor is that we might be disturbing the other normal follicles and decreasing the ovarian reserve for these patients. So we have to be very, very judicious and selective in patients whom we offer laparoscopic ovarian drilling.
Rightly said. And Gunjan, in patient who finally managed to become pregnant, and I'm sure the PCOS should not get disheartened if their first IVF cycle fails, because normally these patients do very well and the cumulative pregnancy rate is quite good. But once the patient is pregnant, any specific precautions that this patient needs to be careful about or needs to take while her pregnancy is going on?
Yeah, for that, I would like to go back to the basics. First, we have to see that PCOS is a progesterone deficient state. So they are more prone to have repeated miscarriages. They are more prone to have preterm labors. Then they have vascular changes. So they are more prone to develop pregnancy-induced hypertension. And thirdly, insulin resistance is an underlying factor. And hence, we have to be very careful about the possibility of them becoming a gestational diabetic patient, just having GDM. So because of GDM, they can have large babies leading then finally landing up in a cesarean or operative delivery. And these children post-delivery can also have problems. So in the patient, once a PCOS patient gets pregnant, she should be monitored very closely, even antenatally. A good antenatal supervision is required. They need to be delivered in a hospital setting. The hospital should have a good nursery facility. So these are some things where we have to be very careful and take them through the pregnancy time as well.
And sometimes what happens is, Dr. Gunjan, the patient comes and we tell them the diagnosis, or you have a PCO. And the first thing is they get very dejected, they get very depressed. And the first thing they ask is it life-threatening? Or what
yes.
do you say about it?
Well, I would like to say that it is not life-threatening, but definitely it is life-engaging. Because as we have to be on guard right from puberty up till menopause and beyond. So it is a major cause of female morbidity and mortality. And it doesn't stop till it at that, because it also carries a risk of transmission to the next generation. So I would like to say that as it is in our genes, we cannot cure it. But we can keep it under control and maybe suppress it. So, and at the end, I would also like to say that because we cannot control it or cure it, we can keep it suppressed. The treatment should also have awareness, early detection, constant vigil, and a timely intervention for these patients. And then, of course, she can have a healthy lifestyle once she is aware of the problem and its consequences.
Correct. My last question to you, Gunjan, that what is the role of birth control pills in a PCO who is undergoing a fertility treatment, not the adolescent, not for menstrual irregularity? Because when we prescribe these birth control pills to a few PCOS patients, they get confused that I have come for fertility treatment, but they are giving me birth control pills. What is the basis behind to which category of PCO patients we do prescribe birth control pills?
Well, this is a very good question, and it is very commonly encountered with most of us gynecologists. Birth control pills are used because this is a hormonal imbalance problem, and it has to be countered by a hormone only. Birth control pills simulate our normal physiology. So by giving them small amounts of hormones, we can correct their hormonal imbalance. So the patients whom we like to prescribe birth control pills are those who are coming to us for menstrual problems, for menstrual irregularities. Birth control pills are a very good substitute for that. They are short term and they carry minimal risk, side effects, and they can be tapered off to let the normal, till the time our lifestyle modification and other modalities help, then they can be tapered off. Secondly, they are given for patients who have, as part of our IVF stimulation protocol, we are using birth control pills. They help in cyst, not letting the cyst being formed. They are also given to patients who have slightly excess male hormones. So then the condition of hirsutism and acne, they can be taken care of with birth control pills. And well, in patients who have very prolonged periods, there is a risk of them having endometrial hyperplasia. In those cases also, we like to prescribe birth control pills to counter the unopposed estrogen. So these are some indications.
Right. Thank you so much, Gunjan, for such an elaborative, detailed this discussion on the PCOS. So the take-home message for our audience is that you can get pregnant with PCOS. The only thing that you need is a little patience, dedication to change your lifestyle, to come out of that comfort zone, have a moderate degree of weight loss, inculcate healthy lifestyle, and of course lose weight. And in some cases, fertility medication alone will help you to get pregnant. And if that doesn't work, you may need an IVF treatment. But regardless of whatever the treatment you explore, don't lose hope. Success rates are definitely very optimistic in such patients. Am I right, Gunjan?
Absolutely. That's absolutely well summarized.
So thank you so much, everyone. And we look forward to answer any of your queries that you have. Dr. Gunjan is there. You can email your queries to us, or you can write them on the Facebook. We'll be ready to help you out. Thank you so much. Thank you, Dr. Gunjan.
Thanks.